about this case. But it gives me a great pleasure to present to you Dr. Kristien Boelaert. I think the pronunciation may be wrong, but I think she's a Professor Kristien. She's a consultant physician and endocrinologist at Birmingham University and Queen Elizabeth Hospital, Birmingham, Boston. And she's a professor of endocrinology at Professor of Endocrinology at Birmingham University. I mean, she graduated in Belgium, 1995. Then she went to do her PhD in Birmingham University, supervised by Professor Jane Franklin. And then after that, she was proceeded to become, after that, at the end, professor of endocrinology. She contributed a lot. She is the main contributor to NICE guideline in thyroid management and thyroid cancer management. She is also contributed at the Royal College of Physicians, Thyroid Society of Great Britain, and even the American Thyroid Society. So you could see her everywhere, and she contributed a lot to thyroid management. We are really grateful for her to be in Bahrain, which is really exceptional to find her. And I think she's going to speak to us about the paradigm shift in thyroid cancer management, and we're looking forward to her speech. Thank you very much.
Thank you very much for that very kind introduction. I'm blushing now. Right, paradigm shift in thyroid cancer management. Here are my conflicts of interest. So what I'll be touching on, because discussing the whole of thyroid cancer in half an hour is not possible, but I want to focus on low-risk differentiated thyroid cancer, because that's where I think most of the paradigm shift has come in recent years. And then I have a few slides on the management of advanced thyroid cancer. So in low-risk thyroid cancer, we will look at the various risk stratifications, extent of surgery, the need to administer radioactive iodine ablation, what we do with TSH suppression, and then how do we follow these patients up. We will then end with a few slides on targeted therapies for advanced thyroid cancer. So I'm sure this audience knows that thyroid cancer, by and large, originates from thyroid follicular cells, resulting in differentiated cancers, the large bulk of which is papillary cancer, and to a lesser extent, follicular cancers. Anaplastic cancers are dedifferentiated cancers that started off as differentiated carcinomas, and then the parafollicular cells are the cells where medullary cancers originate from. And I won't be talking much about medullary cancer this afternoon even. So as is true in the United Kingdom and the United States and in Gulf states, there has been an explosion of thyroid cancer in recent years. So these are the most recent data from Cancer Research UK, showing over the last 30 years an explosion of thyroid cancer both in women in pink and in men in blue. And that is largely due to the detection of a number of low-risk thyroid cancers, the majority of which will be papillary cancers. It's estimated that in the United States, there will be 43,800 new cases in 2022 and about 2,230 deaths. So the death rates may have gone up slightly from thyroid cancer, but nothing in comparison to the incidence. And like I said, that is because we find a lot of low-risk indolent tumors, and that's why a paradigm shift was needed in order to deal with these low-risk cancers, which, if we're honest, we have been overtreating for years. So I just have one case, and maybe we can have a show of hands as to what people would do. But so this is a 48-year-old male who presents with a 6-month history of a lump in his neck. He has no other significant symptoms. He has a palpable 1.5 centimeter right-sided neck lump that moves with swallowing, and no palpable cervical lymphadenopathy. He is euthyroid, has a TSH of 2.1, and you can see here his thyroid ultrasound. So this shows a hypoechoic nodule with microcalcifications and internal blood flow that has a bit of an irregular margin. So this was graded, where I work, we use a U classification, which is very similar to a THYROIDS classification, but so this would be U4 THYROIDS 4, so a suspicious nodule, and then there were no suspicious cervical lymph nodes, and when a fine needle aspirate was taken, this was classed as a malignant fine needle aspirate with a Bethesda classifications of 6, so diagnostic of papillary thyroid cancer. So the question is, what do we do now? Do we remove the whole thyroid gland? Do we remove the whole thyroid gland and recommend that there is remnant ablation? Do we do a right lobectomy? Do we do molecular profiling of the fine needle aspirate? Or do we recommend that we will just keep an eye on this patient? So any takers for A? B? C? D? Or E? So I think I'm with the majority here. I would do a right lobectomy or recommend a right lobectomy. Now, if I was giving this talk about 8 years ago, it would be simple, because the mainstays of treatment, surgery, radioiodine, and TSH suppression, is what every patient got. More advanced cases would then get external beam radiotherapy, not really much success with chemotherapy, but targeted therapies started to evolve. So, like I said, it was simple. There would be no discussion here because all patients would have a total thyroidectomy, they would have a remnant ablation, and they would have TSH suppression. And we would tell these patients, you are going to be seeing me for the next 20 years because we need to follow you up because there is a risk of recurrence. Now, with this explosion in thyroid cancer and the fact that these are actually very low-grade indolent tumors, that clearly is not the right approach. So the main risk stratification that we have post-surgery is the TNM staging. So this is universal for all cancers, grades the size of the tumor, whether there are lymph node metastases and whether there are distant metastases. And this is a very good system to predict death from disease and overall prognosis, but does not really account individual treatment responses, nor does it predict the risk of recurrence. And the issue is that patients with low-risk thyroid cancer, which is the vast majority of them, don't die from thyroid cancer. So what we need to do is assess how do these patients respond and how likely are they to recur. So the American Thyroid Association, the British Thyroid Association, and the European Association recommend that we do a post-operative risk stratification where we class tumors as low, intermediate, or high risk. So high risks are those that have extrathyroidal invasion, distant metastases, or when the surgeon has not been able to resect everything. What all current guidelines also recommend is that we do a dynamic risk stratification. So this is done about, in the UK we do this 9 to 12 months. These are the most recent data, which is from the European Oncology Association. But essentially, whether you do it at 9 to 12 months or 12 to 18 months doesn't matter, but you assess the response to treatment. And so response is excellent, graded as excellent, indeterminate, or incomplete. And it can be incomplete because you can detect serum thyroglobulin, or it can be incomplete because there is structural disease present in the neck. And how this is defined very much depends on what treatment the patient had, whether they had a lobectomy, whether they just had a total thyroidectomy, or whether they also had remnant ablation. So in excellent response categories, there is nothing to find on imaging, and thyroglobulin and antibodies are negative. In biochemically incomplete, thyroglobulin will be raised. In structural incomplete, in summary, the details are in the table, but in summary, there is some disease present in the neck. So, like I said, we used to recommend total thyroidectomy for most patients, but this is actually quite a nice study published late last year, 2021, in the European Thyroid Journal, where there was a significant number, 295 patients, who underwent lobectomy only for thyroid cancer. They were followed up for a long period of time, so between 1970 and 2010. And you can see that out of these 295 patients, so the bottom line is here, 95.6% of patients were in remission after a long period of follow-up. Okay, so the majority of these had always been free of recurrence. There was about 18% where there was a further suspicious event, but you can see that with further surgery, the majority of these were cured. So even if a patient who's had a lobectomy then has a recurrence, this is salvageable with surgery. Okay, there is no need to take everyone's total thyroid out, give them radioremnant ablation, and suppress their TSH. So, extent of surgery. So again, this is from the most recent European guidelines. So we are all anxiously awaiting the American Thyroid Association guidelines. So this time they've gone for nodules and a cancer guideline. I would have thought that that will come out in the next year or so. A number of my friends are on these guidelines. But essentially for these low-risk cancers, so this is differentiated thyroid cancer, a T1A staging, which means a tumor less than 10 millimeters or less than a centimeter. The options there are, especially if there are no other risk factors such as radiation exposure, a family history, evidence of extrathyroidal extension, you could actually just keep an eye on this. And increasingly, we are doing active surveillance of these tumors. Or, in the majority of cases, this will still be treated with lobectomy. You would not, in this case, do a total thyroidectomy. So definitely less than 1 centimeter. What about the slightly larger tumors, so T1B and T2? Again, a number of these are treated with lobectomy, and the slide I showed you just a minute ago, they also included tumors over 4 centimeters. So in the UK, we would treat anything over 4 centimeters with a total thyroidectomy, but many of the ones that are between 2 and 4 centimeters, especially if there are no other features that make us worried, we may treat with a lobectomy and then follow the patient up. So what about active surveillance? So this started a lot in Korea. So in Korea, there's a lot of thyroid cancer because essentially everyone in Korea has a thyroid ultrasound. And all you have to do to find thyroid cancer is do a thyroid ultrasound because you have a 1 in 2 chance that the patient has a thyroid nodule and 30% of us have a microcarcinoma in our thyroid. So very high likelihood. So they started, quite rightly, actively surveilling some of these patients. I'm not saying it's right to ultrasound everyone's neck all the time. I don't think that's right. But that's the situation they're in. So the most recent study performed by my friend and colleague Megan Haymart included 7 studies, 1,219 patients. Most of the data are limited to the small microcarcinomas, so those less than 1 centimeter. And it seems that active surveillance may be similar to surgery with regards to mortality, risk of recurrence, and other outcomes. However, the data are very heterogeneous, so there have been a number of systematic reviews and meta-analysis performed, and so the data is not clean, and it's therefore difficult to judge this. A number of confounding factors, and it is very clear that further research is needed here. But I think increasingly and more we're going to see that we're actually going to keep an eye on some of these very small indolent thyroid cancers. What about radioactive iodine ablation? Again, here, this is from the European guidelines. What I'm talking about is the left-hand side here, so not the radioiodine therapy, which you give for more advanced disease. So this is remnant ablation. So in the low-risk cancers, especially in the microcarcinomas with no evidence of metastasis, we would not give radioactive iodine. Again, in the United Kingdom, for many of the other low-risk tumors, we would not give radioactive iodine. So certainly someone where you only do a lobectomy, you would never give radioactive iodine, okay? You need to remove all thyroid tissue if you're going to give radioactive iodine, and you need to have a good reason to give radioactive iodine. So we're using this much less for thyroid cancers. What about the dose of adjuvant radioactive iodine? Well, in 2012, we had 2 trials simultaneously, the HILO trial in the UK and the Estimable trial in the rest of Europe that looked at a high dose versus a low dose radioiodine ablation. Because again, 15 years ago, everyone would get a standard dose of 3.6 gigabecquerels. What this did was comparing 1.1 and 3.7 gigabecquerels and also whether you do thyroid hormone withdrawal before ablation or whether you give recombinant TSH. This was a non-inferiority trial, and it showed that the low dose was as effective as the higher dose. And of course, there were fewer side effects with the lower dose, and recombinant TSH is generally is nicer for the patients because they don't become very hypothyroid. We've had a further follow-up study of the HYLO trial because, of course, these endpoints were determined quite soon after we did this. But essentially what this here summarizes is that there were no late or very few late recurrences. And again, therefore, that this low-dose radioiodine is safe. So for the majority of low-risk cancers, if you give radioactive iodine, low dose will be fine. We are awaiting the results of the ION trial, which looks at low dose versus no radioiodine, and those data are being analyzed as we speak. What about TSH suppression? And that's, of course, something we're very interested in as endocrinologists, because the reason here is that we want to suppress TSH, which is a growth factor for thyroid cells. And again, many of these patients, certainly 20 years ago, we used to suppress their TSH for many, many years. So this is a nice study looking at 5,000 patients who'd had a lobectomy, so they, by definition, had low-risk cancer. And you can see that whether their mean or their dominant TSH concentration was kept very low during a period of follow-up or not, these Kaplan-Meier curves all overlap. So it showed that actually suppressing TSH to below 2 didn't really matter in these patients. There were very few recurrences, 1.4% during a long period of follow-up. Because, of course, if you suppress someone's TSH, and this is something we worry about in patients who present with endogenous subclinical hypothyroidism, are the long-term consequences. So we worry about their heart, we worry about about osteoporosis, and we worry about dementia. And so this has been studied specifically in thyroid cancer patients. So I can't show all the data, but this is a study here looking at 901 patients who were treated for differentiated thyroid cancer. And you can see that patients compared with controls had a significant increased risk of cardiovascular disease, mainly arrhythmias, and it's atrial fibrillation that these patients suffered from. And this was specifically for patients whose TSH was kept below 0.1. Like I said, osteoporosis and dementia are also further risk factors of suppressing someone's TSH. So this is from the American Thyroid Association, but all guidelines adopt a similar approach. And as always in medicine, this is about balance of risk versus benefit. So if the patient has and it boils down to this dynamic response. If the patient has had an excellent response, then it's probably not necessary to suppress that TSH for any period of time. As you go up here with the risk that the tumor carries, you may consider TSH suppression, but you also have to take these other factors into account here. Is this patient postmenopausal? Does this patient already have cardiovascular disease? Does this patient already have osteoporosis? So it's individualized. We're living in an era of individualized decision-making for patients. So what is right for this patient, taking everything into consideration? And again, so it can be very difficult because we have told, or certainly some of my colleagues have told these patients, well, we will be looking after you forever. And now I come there and they think, who's this woman? She doesn't know what she's talking about, because I say, well, actually, we can discharge you. It's good, you're cured. We can discharge you. You've had an excellent response. And we have to remember that for tumors like breast cancer, lung cancer, often patients in the UK are discharged after 5 years. So, and these are much more aggressive tumors. So what we deal with here is a very low-risk cancer. So we should offer discharge definitely after 5 years if they've had an excellent response, therefore no evidence of residual disease, they have a TSH that's within the normal range, and no evidence of thyroglobulin antibodies. For these low-risk patients, we're increasingly doing nurse-led follow-up in the United Kingdom, and I think we've all become very adept at remote consultations and virtual consultations in any sort of patient that we see. But again, these patients are ideal for this. Thyroglobulin measurements, so it's recommended that we use a sensitive assay, always measure thyroglobulin antibodies together with thyroglobulin, and beware of other interfering factors. So my colleague and friend Carla Moran already highlighted that this morning, how biotin and other things can interfere with assays. It often is a trend in thyroglobulin that's more informative rather than an absolute value. And a doubling time is something that we really take into consideration. So know your assay, know what your laboratory does, but look at serial measurements. And for most of these low-risk patients, we don't have to stimulate thyroglobulin. So you might want to do that for dynamic risk stratification, but increasingly we do dynamic risk stratification with an unstimulated thyroglobulin, so taken whilst the patient is on levothyroxine. If a patient has had a lobectomy, thyroglobulin measurements probably are of little value because the patient has half a thyroid there, so thyroglobulin is going to be there. But if you measure it again, serial measurements may be helpful. And there is some evidence that when those patients who do have remnant ablation, their serum thyroglobulin on the day of ablation, if that is undetectable, then that is a very good prognostic indicator. What about continued imaging? This is a very busy slide. This is the European guidelines they're very busy algorithms in my opinion. What I'm focusing on here is the bottom bit and mainly this side of the slide here. So the low-risk cancers. I don't think you should continue to repeat neck ultrasounds in those patients where you've deemed they've had an excellent response. There is no need to, unless there is a clinical change, to continue to do their ultrasound. Obviously, for those patients where there is an incomplete or structural response, more regular ultrasound scanning will be needed. Sometimes what we do in patients where we've done a lobectomy, especially if there's a nodule on the other side, those are again patients where we might do more imaging, and again this is an individualized decision making. So I'll just move tack slightly now then and look at the other side of the spectrum. So this is advanced differentiated and medullary thyroid cancer, but mainly differentiated. So this slide here very nicely summarizes a very recent publication, summarizes all the various agents that are available. So these are multi-kinase inhibitors. So the two main molecular pathways involved in thyroid cancer are the RAS pathway and the PI3 kinase pathway. And so these are governed by these receptors here. And so we have a number of agents often that interact with many of these receptors, mainly the VEGF receptor, but MET, the IGF receptor, RET, they've all been implicated, and various agents will interact and block at the site of these receptors. So I think the most known ones are sorafenib, lenvatinib, and cabozantinib, and then for medullary cancer, vandetanib. But you can see there is a wide array of agents available here. And of course, it sounds very good. You have a patient with progressive advanced cancer, or we have a targeted treatment. I thought this publication quite nicely summarizes what you should do if a patient has recurrent or metastatic disease. Because I think the first port of call for radioactive iodine refractory, so this is patients who've had repeated doses of therapy doses of radioiodine, is that you should see if there's anything that you can remove surgically, because that will always be the best chance for the patient. Is there anything that can be done surgically? Can we use external beam radiotherapy? But what we're talking about here is these patients where all this has failed, who don't take up radioiodine on a scan, and who therefore have radioiodine refractory disease. So by definition, these are patients where other treatments have failed, who have symptomatic or potentially symptomatic disease, where the disease may threaten vital structures, and because these medications really come with significant side effects, the patients need to have an acceptable performance status. So if this is a very frail, bedbound patient, then these treatments are not going to be suitable. But this is where genetic profiling then comes in. So a genetic interrogation of the tumor specimen is important. If you find a genetic alteration and there is progression, then there are tyrosine kinase inhibitors and multi-kinase inhibitors available. Sometimes we don't find a genetic alteration, and especially in those patients where there is a tumor burden over 2 centimeters, again, you can consider multi-kinase inhibitor initiation. So very much in my center, that is something that I do in conjunction with the oncologists. I don't give these treatments because I've just listed the main side effects here of multi-kinase treatments. So those of us who've had patients on this will know that diarrhea, fatigue, hypertension, hepatotoxicity, skin changes. Beware that once you start multi-kinase inhibitor treatment, these patients are often, are by definition atariotic, and often you need to increase their dose of levothyroxine because there is an effect of the multi-kinase inhibitors on thyroid function. And then the newest kid on the block is selpercatinib. This is a treatment that's been shown, so this has been used in lung cancers, but has shown very promising results in RET-altered thyroid cancer. So this is a selective RET inhibitor, has been successfully used in RET-mutant medullary cancer, but also in RET fusion-positive differentiated cancers. And even in patients who've previously been treated with other agents, such as vandatinib and cabozantinib, you can see that there is a very significant response rate. But very importantly, in the phase 1 and 2 trials, this is associated with significantly less side effects than the other multi-kinase inhibitors. So certainly, very recently, selpercatinib has been approved by NICE in the UK. It's very difficult to get any of these agents approved in the UK. Selpercatinib has been approved in very specific indications. So what are my main messages? I think less is more in the management of most thyroid cancers. Low-risk differentiated thyroid cancer has an excellent prognosis and generally does not recur. For many patients, we can do either active surveillance or lobectomy. Choose your patients who need remnant ablation. Generally, I think we can relax TSH suppression and balance that with potential side effects. And there is no need in general to use stimulated thyroglobulin measurements, definitely not repeatedly, and discharge your patients. It is okay to let these patients go. We cannot have all our clinics full of low-risk thyroid cancer patients. There is a large array of targeted treatments, and unfortunately time doesn't permit me to dwell on too much, for radioiodine refractory differentiated and advanced medullary cancer, and we have some new kids on the block that show very promising results. Thank you very much.
Grateful to you. Thank you very much.
Pleasure.
Any questions?
Kristien, excellent as usual. Can you hear me? Yeah. Just a question about the people who have high antibodies, anti-TG antibodies. How do you approach these?
Very difficult. So again, it's serial measurements there. So the recommendations are that, so you measure thyroglobulin and then, I'm sure everyone knows this here, but so the thyroglobulin antibodies make the result of the thyroglobulin uninterpretable. So again, there it's serial measurements. And also the actual level of antibodies is important, because if those antibodies go up, that means something is going on. If a patient previously had an undetectable thyroglobulin and they develop antibodies, again, that indicates something is going on because an antibody reacts to an antigen. So something is going on. So it's about serial measurements. Be helped by imaging. You may need to resort to cross-sectional imaging in these patients, but difficult.
Thank you.
Okay.
Thank you so much. Two quick questions. When do you decide to repeat iodine scan in somebody who has been negative before, and now developing new metastasis? Do you repeat scan in such person? And second, when do you start to aggressively pursue recurrence using PET scan or other methods versus just wait and observe in somebody who has some disease, but either by TG or a little bit of incomplete structure, and you've been observing for a while?
Okay, maybe stay at the microphone just to make sure that I've understood your questions correctly. So I use very little iodine scanning now actually in these patients, because we follow up with thyroglobulin, we follow up with ultrasound. If thyroglobulin is rising, you don't find anything on ultrasound, then it's cross-sectional imaging. And if we still can't find it and thyroglobulin continues to rise, then I think a PET scan is more informative. A radioiodine scan can help us identify those patients that may be radioiodine refractive. But again, that often is after multiple doses of therapy. So I think we used to do a lot of iodine scanning. We didn't have such sophisticated other scanning modalities available. I don't recommend routinely PET scanning many of these patients, but it can be a very useful tool here. When do I decide to more aggressively pursue it? Well, as an endocrinologist, I like thyroglobulin measurements. I think biochemical measurements are really helpful here. A doubling time of thyroglobulin is very important. if that starts to rise, and it's very similar in medullary cancer, because we all have these patients with medullary cancer that are okay for many years, even though they have a slightly raised calcitonin, you know, they have known metastasis and they're stable, and suddenly it explodes. Suddenly that calcitonin or thyroglobulin starts doubling, and those are patients where you just keep chasing it until you find it. And then you need to decide, is it something that we can surgically treat? Hopefully, if not, and the patient is in an, you know, it's performance status of patients often that determines whether they can go for these multi-kinase inhibitors or not, because these are not smarties. These are drugs with significant side effects, and the patient needs to be very fit for that.
Okay, thank you. So
Thank you
what
very
I
much.
meant, if somebody came up with new metastasis that was not there before, and he had previously an iodine scan that was negative,
Yeah.
and now there is lung or bone lesion, do you go back and check whether there's an uptake, or you just call this patient negative?
You mean on an iodine scan?
Yeah.
A patient who had a negative iodine scan and then develops a lesion on an iodine scan, oh, that needs chasing. That needs chasing with everything you can. And if necessary, you need to surgically go in and try and find it.
Thank you.
Okay, last question, please.
Yeah. Because they scan everybody. If we scan the whole population of Bahrain, I will give you an explosion of thyroid cancer, low risk microcarcinomas.
We shall all that patient.
So I think we'll leave that. Thank you.